Frêmito, o podcast vascular do perfil O Fogart da Madrugada.
Bem-vindos de volta ao Frêmito, o podcast vascular do perfil Fogart da Madrugada. Você já conhece o nosso trabalho no Instagram. Toda a nossa produção científica e de humor é independente e autoral. Você confere também uma charge mensal na SBACV em Pauta, a revista da SBACV Nacional. Eu sou o Arthur Curtarelli e, compondo o time do Fogart da Madrugada, estão comigo o Luiz Eduardo de Brasília.
Tudo bem, pessoal? Estamos de volta aí para um novo episódio. Vamos lá?
E o Fábio Goldbach, de São Paulo, capital.
Olá, bem-vindos a todos para esse próximo episódio aí muito especial, para essa conversa.
Antes de começar o nosso episódio, para você que está nos escutando, não deixa de apertar o botão de seguir aqui no Spotify. Isso é muito importante para o nosso trabalho e ajuda o nosso time a continuar produzindo. Hoje é um episódio muito especial, a gente está aqui em Nova York, né? Queria agradecer ao Fábio pelo voo fretado que ele conseguiu aqui, a gente está em Manhattan gravando essa entrevista.
Com esse dólar dá para talvez consumir um kebab na rua, velho, eu posso te pagar.
Adorei o Airbnb aqui na Times, viu, Fábio? Obrigado. O tema hoje é ultrassonografia vascular com Doppler e para conversar com a equipe do Fogart da Madrugada, nós convidamos uma autoridade no assunto e celebridade nos eventos científicos brasileiros. Ele é formado em Medicina e possui PhD pela Universidade de Londres, possui Fellowship Training no Hospital St. Mary's, em Londres, e hoje atua e trabalha nos Estados Unidos, onde é professor e coordena o laboratório não invasivo em diagnóstico vascular da Escola de Medicina da Universidade de Stony Brook. Estamos honrados em ter conosco o Dr. Nicos Labropoulos. Boa noite, doutor.
Boa noite. Primeiro, Arthur, Fábio e Luiz está muito feliz que tem que participar alguma coisa brasileira, né? Está um prazer para mim grande. Por favor.
Obrigado, senhor professor, pela disponibilidade. A gente sabe, professor, que o senhor é da Grécia e que fez grande parte da sua formação na Inglaterra e hoje está trabalhando nos Estados Unidos. Então, uma longa carreira aí em vários continentes. O senhor pode nos contar um pouco sobre essa tua trajetória? Como é que foram essas mudanças profissionais?
That's a very interesting question, because as you know, our life is a combination of random events. I never planned really to go to England or to the United States. I grew up in Greece and I was one of the talented kids. You know, I have a lot of charisma growing up. And for example, when I was in the primary school, I read an entire encyclopedia in 2 years. Then at the age of 13, I developed my own theorem in mathematics. And then since I had so much, thirst for knowledge, I decided to go to a bigger university outside Greece. And I was fortunate to go to Imperial College in London, which is one of the best places on the planet. But even when I was there, my life was running ahead of me. So I had many invitations from the United States to go and work or visit there. So I chose, just for better or worse, to go for 1 year only in Chicago. And I went to the Loyola University Medical Center. And when I finished 1 year, the people asked me, Nicos, stay for another. So I stayed for another, and never went back. Eventually, 10 years later, I went to New Jersey for 2 years, and now I'm in New York for 14 years. And that's the life. It is the trip, not the destination, that makes life more beautiful.
Perfeito. E doutor, aproveitando essa jornada que o senhor citou, o que foi que despertou e como foi que o senhor passou a se dedicar especialmente com a ultrassonografia vascular?
Luis, this is another random event. When I was in the medical school, I had to do one project to graduate. And I never knew this person, but I liked circulation. And a very famous person for circulation was Professor Charles Michel, who's the head of physiology and biophysics for the Imperial College, the St. Mary's School of Medicine. And I went to him, and he offered me to do animal experiments. I said, Professor, I like to work with humans. Aha, he said. Why don't you go and meet the chairman of vascular surgery, Professor Nicolaides? And in fact, I made an appointment with him, and he asked me to meet him inside the operating room. He was operating on a vicar from Cyprus. He was doing an alto coronary bypass. And I was very impressed seeing how he stopped the heart and make the bypass. And at the same time, he was interviewing me, right? And he said, Nicos, listen, here we have a laboratory, a vascular laboratory. Here is a book for statistics and a book for ultrasound. You have 1 week to learn both, and then you can work with us. So I did my project, and actually it was fascinating because at a young age, I developed one of the first criteria for detecting stenosis of the superior mesenteric artery and the celiac artery. That was in 1990. And then they give me an unconditional offer to do a PhD and fellowship with them. And it was interesting because at the same time I have an offer from Cambridge University and from Oxford. And I turned both of them down because Imperial College is the best place for vascular disease in the world. So I was very happy to be there. And the ultrasound was just an accident. The project was about ultrasound, and then it became a hobby.
E, Dr. Nicos, uma pesquisa rápida no PubMed mostra que o senhor possui aí quase 300 artigos e mais de 15 mil citações em diversas áreas da ultrassonografia vascular. Como o senhor enxerga a importância da pesquisa na prática clínica dos cirurgiões vasculares?
Fabio, this is a very important question because, as you know, there is no progress without doing research. So for me, it's fundamental, a physician, a doctor who is also a scientist, to do some type of research to expand his horizons and his career. As you know, progress is inherent in the human nature, and you cannot stop it even if you try. And always you try to move forward. It opens a door for many things and also allows clinicians to become critical, objective, and better at their work. So the modern doctor should not be afraid of the research, but he or she should see research as a pathway in becoming a better clinician, a better doctor and scientist.
Bom, Fábio, temos que tirar aqueles trabalhos lá que estão engavetados, né? Pra gente voltar. Fica aí a dica, né? Pra gente puxar aquilo, a bibliografia lá. Professor Nicos, dentre os temas venosos observados, grande número dos artigos ligados à insuficiência venosa crônica das suas publicações. E também sobre síndrome congestivas pélvicas. Quais os conceitos ultrassonográficos básicos que todo vascular deve dominar nesse tema?
Yes, Arthur, like with anything else, we need to understand the structure, the way we are made, the function, the way our body works, and from under which conditions our body suffers from different pathologies. So when you put these concepts together, it's easier to follow any subject, right? And in this way, as doctors, we can offer better diagnosis and treatment. On this particular field, we have developed protocols for examination of the lower extremity veins and also the pelvic veins. In fact, right now, together with the Society of Interventional Radiology, the American Society for Vein and Lymphatic Disease, and the American Venous Forum, we have made a new publication which is called SVP, which is basically a new classification, and we don't call it anymore pelvic congestion syndrome. We call it, pelvic vein disorders. Like in the lower extremity, you're having reflux, obstruction, or both. And in modern medicine, we try to avoid the word syndrome because the word syndrome is usually confusing. We try to be more specific using topographic anatomy, the exact location, and the exact symptoms and signs. And because for the pelvic disease, yet we don't have a good instrument to validate the effect of the treatments, after we made this classification, now with another committee, we're developing an instrument to study properly what is the specific effect of treatment on pelvic vein disorders, like we have done for the lower extremity with the CF classification and with the quality of life questionnaires like the VNS, for example, right? And other things like that. And I believe the modern physician has to understand these basic concepts, be able to speak the same language, because in medicine we found one of the reasons that we make a lot of errors is miscommunication. You can have, like in our hospital, just one of the 4 units we have, there are 7,000 people. that are made from different layers of people that don't speak the same language. I mean, they speak English, but in medicine, the idioma, right, is different. Therefore, we have to find ways to understand each other. And imagine if this is a problem in our hospital, what happens all around the world. And that's why classifications, right, to have the same names, protocols to follow the exact same, a protocol for an exam for a smart doctor might be boring. But for an average doctor, if you follow the protocol, like the pilot does a check on the plane, you don't make mistakes, you avoid mistakes, right? And you can do shortcuts only when you feel safe and you understand the subject. Anyway, it's a small idea of how somebody should evolve in this field, particularly the pelvic, which is less explored.
E Dr. Nicos, ainda sobre a síndrome de congestiva pélvica, em pacientes com sobrepeso ou com preparo intestinal inadequado, algumas vezes não conseguimos ensonar a confluência das helicas de forma adequada. Com o objetivo de aumentar a presunção diagnóstica, foi desenvolvida uma relação de velocidade de fluxo da veia femoral comum esquerda sobre a veia femoral comum direita. Como podemos utilizar e acreditar esse índice?
There are various ways. First, the patient preparation and the patient positioning are important. Ideally, if you look at the abdomen and you have direct visualization, the patient can come with overnight fasting, not necessary, but good if possible. Then try many different windows and techniques to visualize the problem directly. If you don't have experience looking at the vein directly, or you don't have acoustic window for direct visualization, then you can use what we call indirect signs, such as the common femoral vein, it's very easy to see, and see asymmetry between the two common femoral veins, or if you like, to see a non-phasic waveform. In fact, a non-phasic waveform in the common femoral vein guarantees proximal disease, where a normal waveform cannot exclude it. Furthermore, other conditions like the inferior epigastric vein has flow from the abdomen to the groin. If the flow in this vein is from the groin to the abdomen, for sure there's obstruction, right? And these veins are very easy to see even with a linear transducer, right? And will help you. And of course, use your clinical judgment. Does the patient have unilateral swelling? Does the patient have venous claudication? Does the patient have skin damage in one area? Etc. So you have to put the clinical context together with the findings to guide you for a proper diagnosis and eventually proper treatment.
Professor Nicos, hoje muito se fala das varizes de membro inferior de origem não safênica. O que esse termo significa e quando devemos suspeitar desse diagnóstico?
Yeah, it's a very interesting question because it unfortunately, many of the practitioners do not know that the non-saphenous veins are very common. In fact, 1 every 10 patients with varicose veins has some non-saphenous vein with a problem. And if you're used to treating the saphenous veins only, you can undertreat disease basically, or more importantly, you can treat the wrong vein without knowing it. So these veins are most often found in female patients that have at least 2 pregnancies, and they're associated, not always, but most often, with pelvic varices, right? Such as in the vulvar area, in the gluteal area, in the perineum, and also deep inside from the sciatic nerve as these veins connect with the inferior gluteal vein. Now, in people who come with recurrent vein disease, the prevalence increases. Instead of 1 out of 10, it's doubles. 1 every 5 patients has non-saphenous varicose veins. And sometimes you call it recurrence, but sometimes it might be a residual disease because these veins, they're never treated properly to begin with. That's why in people with recurrent disease, the incidence is double. As shown by our paper in 2001, 2006, and the paper by Bernardini in 2011. And also a second paper with a good friend of mine, I talked to him. He was a medical student when I met him in 2007 in Goiânia, in Sociedade Brasileira de Cirurgia Vascular. And now he's a vascular surgeon, he's one of my trainees. And with a paper on non-saphenous veins in 2013, talking about the patterns of non-saphenous vein reflex, basically. And they are demonstrated clearly additional veins such as, the perforator that comes from the thigh and is connected to the profunda, the vein of the popliteal fossa that's often confused with the small saphenous vein, atypical knee perforators, or combination of these things.
Professor, e quais são os estigmas clínicos e também os achados ultrassonográficos que levam o cirurgião vascular a pensar que o problema vem da pelve e não do eixo safênico?
First, the signs and symptoms of venous disease are not specific. However, in a clinical context, we said if you look at the female, like 2 pregnancies, right? If you look varices that are coming from the pelvic area, like in the inner thigh, posterior medial thigh, right? Or veins that come from the sciatic nerve, you got to suspect pelvic vein disease. And that's very important because sometimes the patient is symptomatic on the leg and asymptomatic in the abdomen. So if you have no symptoms in your pelvis, you don't think of the pelvis. However, non-saphenous veins and sometimes saphenous veins, right, in the lower extremity can indicate that there's a problem higher up. And that's why you have to put the clinical problem together with your physical examination and what you see. More importantly, because a lot of us, we don't do proper history physical exam, you have to stand up the patient, inspect the leg in all 4 areas, and if you don't want to look at the valvular area, you can ask the patient, do you have any veins there? Or if it's a male, you can ask him any testicular pain and so on. Usually this will be a referral from a general practitioner or a urologist if it is for a male. But for a female, usually they come to us, they have varicose veins or come directly for a problem with the pelvis, or both.
E Dr. Nicos, ainda sobre a insuficiência venosa crônica, o valor de corte de refluxo fisiológico e patológico das safenas, apesar de já bem conceituado, ainda está sob indagação. O que significa na prática um refluxo patológico?
This is a very important question in medicine because in medicine we have developed values from normal and abnormal, right? An abnormal value is above a cutoff, usually 2 standard deviations above the mean value of the normal, right? So it's a made-up value that excludes most of the normals, right? But then this, Luis, it does not give you a license to treat the patient because there is an abnormal value. We don't treat the abnormal value, we treat the patient. Many patients' abnormal values don't need any treatment. For example, a patient has, a stenosis in the SFA and there is disease, right? It doesn't mean you need to put a stent there, right? You can do nothing, actually, in many patients, or use conservative means. Again, the patient with reflux. If somebody has a reflux, 700 milliseconds. So if you correct the vein, nothing will change for the patient. Because how can you explain such a small amount of blood to cause symptoms of the patient? And although we have defined what is a pathologic value, we have not defined very well at which value patients should be treated. And this is because the problem is more complex. Because the patient might have reflux, but is the vein big? How long is the vein segment affected? Does the patient have a previous thrombosis? Is the patient obese? Does the patient lack of physical activity? Does it have a heart failure? You see, it's more complicated. It's not like a vein. And like things in medicine, a doctor, and actually, you say, logica comune, common sense. And this is where you define, it's difficult, for the most part, medicine still in 2021 is art. And it's a little bit of science. When we evolve more as humans and make medicine all scientific, things will be much easier. We have to use art and medicine. That's why we need to use common sense to define, right? And this is not just for reflux, it's just for many other conditions in the human body that we use our judgment. And be careful because in the United States and also unfortunately in Brazil, I've been many times, we often treat the lesion but not the patient. And often this patient does not need some interventional treatment, right? For reflux or putting a stent. He needs some follow-up, right? And if his quality of life is impaired, right, then maybe you intervene sooner than later.
É muito importante isso que o senhor falou. E Dr. Nicos, existe diferença clínica entre os refluxos? Por exemplo, um refluxo curto, próximo a 500 milissegundos, ou um refluxo longo, ou ainda aquele com VPR muito aumentado, eles são diferentes entre si?
In reality, there is, because as you said on the previous question, you have the normal value and the pathologic. pathologic for all superficial veins being more than 500 milliseconds. But this will define that the valve is not working. It doesn't mean something is wrong with the patient. Then you have like some broad categories like reflex more than 2 seconds and reflex more than 5 seconds. However, in terms of volume, it means nothing because you have a tiny vein, 2 millimeters, with very long reflex, and a big vein, which is 10 millimeters, with shorter reflex. So which is the worst? So this is earlier because there are multiple variables that govern the clinical presentation of the patient. We should not base our opinion just in one value. But in general, the longer the duration of reflux and the larger the diameter of the vein, the higher the chance of having more significant problem and requiring treatment. A small example, if I find a saphenous vein that's 3 millimeters big and the reflux is 2 seconds, I won't do any treatment. Unless if it is deliberately for aesthetic reasons and the patient comes to us for cosmesis, not for medical reasons, which are two different objects, right?
Em 2016, professor Nicos, o senhor escreveu um paper falando exclusivamente sobre o tratamento das veias perfurantes. É um tema polêmico, campeão de congresso aqui no Brasil, né? O senhor pode comentar qual a sua opinião sobre o tema na época e se ela mudou passado 4 anos?
Not much has changed, but right now we know only what we call pathologic perforator vein should be treated. What's a pathologic perforator vein? A vein that has more than 3.5 millimeters in diameter, has a reflex more than 500 milliseconds, and is found in an area of an ulcer which is difficult to be treated or has recurrence. And nowadays they have relaxed a little bit the guidelines to include also people with skin damage, possibly to prevent the formation of an ulcer. But however, in all these three conditions, surgery for the perforator veins has not proven clearly to be beneficial. May be beneficial in subgroup of these patients. What we know for sure, people with no skin damage, class 0, 1, 2, and 3 on CF classification, there is strong evidence against treating perforator veins, and it's both in the European and the American guidelines. So I urge all our Brazilian friends, right, not to treat veins, perforator veins, with or without reflux in people having C0 to C3, and think carefully how to select patients with skin damage to treat the perforators only in the area of skin damage.
Dr. Nicos, mantendo ainda um pouco no mundo venoso, mas mudando para o diagnóstico das tromboses. O conceito de TVP aguda, TVP crônica e suas variações foram redefinidos há pouco tempo. Esses critérios são importantíssimos na tomada de decisão clínica. O senhor pode nos explicar um pouco qual o conceito atual mais adequado dessa diferença?
This is an area where we need to do a bit more research. Right now, basically 3 recognized states by ultrasound. One is the acute phase, where the people need to be treated. It usually involves clinically the first 2 weeks, but histologically only the first couple days. And then you have the subacute phase, which is past the 2 weeks, right? But both acute and subacute should be treated with anticoagulation. So it's not so important to differentiate unless you want to intervene with thrombolysis. And then you have the chronic stage. We don't call it chronic thrombosis anymore because chronic thrombosis is an ironic medical term because it doesn't exist. If our thrombus in the human body does not lyse within 6 months, it becomes collagen type 1 primarily and collagen type 3. It's not thrombus any longer. And it's very important because no medicine can lyse collagen. And therefore we call it chronic post-thrombotic luminal changes. And this is very important to recognize because many people have no objective documentation of the DVT, or they never knew they had a DVT, it was asymptomatic. Therefore, if you find the post-thrombotic changes, you need to write on your report because you can do 4 things. Number 1, give chemical prophylaxis if these patients ever undergo surgery, because the biggest risk factor for DVT is the previous DVT. Number 2, if these people undergo superficial vein surgery, to reduce the expectations of the patients because this patient is not going to go back to normal. Number 3, this patient may continue to wear elastic compression stockings. And number 4, this pathology, when identified, can explain partially or completely the signs and symptoms of this patient.
Professor, então o senhor acha que é adequado utilizar a ultrassonografia para definir o tempo de anticoagulação do paciente?
Actually, it can help, but the best way, in my opinion, is the biochemical way. Because the D-dimer is very specific, right, for thrombus lysis. So if your D-dimer is above 500, then you know somewhere in your body thrombus is being lysed. Therefore, if you use the D-dimer, as shown the few prospective studies, like done by Cosme et al. From Italy, right, you are more certain of what's going on and if you should stop or not the anticoagulation. For example, let's assume having a patient has unprovoked DVT and we give anticoagulation for 6 months. At 6 months, we can do a D-dimer, and if the D-dimer is still high, you can continue the anticoagulation for another 3 months. If the D-dimer is normal, then you can stop the treatment right there. Now, in my opinion, the ultrasound, it can help in a similar way. Because if you know what is the extent of remaining pathology at the end of the treatment, then in the next event, you know if the patient gets a new DVT or not, right? And it can also help you to make a decision of how patients should be treated. For example, to put a stent in an iliac vein. For example, to continue wearing elastic compression support, right? And obviously, a patient has wide open veins, and the veins are fully recanalized, you can use it as a prognostic sign that this patient actually will be better off at long term. So therefore, ultrasound should be used regardless of the D-dimer for the reasons I just explained to you, right? To give better, more accurate prognosis and better follow-up care and treatment of our patients.
Professor Nicos, a gente vai mudar um pouco o tema agora, tá bom? Quando falamos da parte arterial, sempre entra em discussão a polêmica dos critérios velocimétricos diagnósticos. Como esses critérios são definidos pelos experts?
Yeah. In my opinion, and the opinion of the experts, the best criterion for most arteries in the human body is the V2-V1 ratio, which is basically based on the equation of continuity described by a very famous Swiss mathematician, it's called Euler. He described this famous equation. It's applicable to any vessel in the human body. And basically, if the V2-V1 ratio, like the poststenotic velocity, is twice as high as the prestenotic, yet 50% diameter stenosis or more. If this ratio is more than 4, then the stenosis is more than 75%. Now, if you want in your clinical practice to reduce the sensitivity a little bit and increase the specificity, you can make this cutoff at 2.5. For other artists, may work a little bit different, like for the carotid, right? Maybe work a little bit different, but more or less are all the same, including the aorta, the popliteal, the commofemoral, the brachial, right? So, and that's why, because this criterion is based on mathematical model, which is phenomenal. It's really very accurate. I don't think we need to rediscover the wheel.
Professor, e qual critério diagnóstico arterial o senhor acredita que precisa ser revisto com urgência?
Well, I think what we need to do on the arterial part is to do direct imaging, like we do with the IVUS and the CAT scan and MRI, right? You see directly the vessel and do what we call planimetric measurements, like area and diameter, because these are not affected by the condition of the heart, proximal or distal occlusion, arrhythmias, nothing. And you use the velocities as complementary, right, to say for sure that both criteria are present. Now we need to validate planimetric measurements. I'm doing such a study on carotids, and I can tell you the preliminary analysis, just excellent correlation. Right, so but of course, when you use ultrasound, the imaging is subjective. So you make sure you follow all the rules of imaging, try to be objective, and then the measurements are really very good. And we do the same thing like for the iliac vein, for example. When we look for the iliac vein, we do direct planimetric measurements. Right? And you can do both diameter stenosis or area stenosis or both.
E assim a gente facilita também aquela parte do exame ser examinador dependente que a gente fala, né, professor?
Exatamente.
Isso aí fica melhor, né? Legal. E agora falando um pouco do exame das carótidas, quando nós utilizamos a espessura média intimal como marcador de aterosclerose e risco cardiovascular, esse conceito é validado e amplamente reproduzido, mas ainda temos algumas dúvidas. Nos pacientes, por exemplo, que possuem uma placa de aterosclerose, é necessário fazer essa medida? E outra dúvida seria se o local mais comum de surgimento das placas é no bulbo e os segmentos iniciais da carótida interna, por que a gente mede na carótida comum?
Very nice, Luis. Now, in the United States, we stopped using the intima media thickness routinely since 2011. That's 10 years ago. Because we know since, and I say that often in meetings in Brazil, because we found no additional clinical value. First, as you said, the plaque is a better predictor for future events, right? Because plaque is declared atherosclerosis with no doubt. Then, the intima media thickness is a good factor for prognostic events, but when applied to a group of people that's 200 or more, in a single individual, it's difficult to make judgment on IMT alone. And more importantly, the traditional atherosclerotic risk factors, like done in the Framingham study, right, are better predictors than the intima media thickness. Therefore, unless you do it for research purposes, in routine clinical practice, I don't think it's useful anymore to use intima media thickness. Right? Don't misunderstand, like for routine clinical practice.
E Dr. Nicos, outro conceito polêmico que recentemente sofreu padronização por guideline foi a nominação dos formatos de onda. O senhor pode nos ensinar a forma correta de classificar uma onda em monofásica, bifásica ou trifásica?
Fabio, yes, because there's been a lot of misnomers, like and the people call different ways the waveforms. Like a triphasic waveform should be when you have forward flow followed by the reverse flow and then by forward flow again. A normal biphasic or close to normal biphasic will be when you have forward flow followed by the reverse flow and absent end diastole. And a monophasic when you have forward flow and almost the entire diastole, there is no blood flow movement. That's the three main categories. Now, the problem becomes when you have two sounds, you have systole and diastole, but because everything is above the line, people call this monophasic waveform. Well, you could call it monophasic if it's above the line, but you could have abnormal or normal. For example, the internal carotid, right, has systole and diastole, but all is above the line, but it's a normal waveform. But if you find this waveform on the popliteal artery without exercise, it will be abnormal. So here is where common sense, right, and how to use it. But now, after this definition that was done recently in the United States, the result and how you call the waveforms is far more clear. So I strongly recommend to people to use the most recent classification, because my opinion is 95% accurate.
O senhor poderia comentar um pouco sobre a nova classificação e como que o senhor sugere que seja abordado aí nos relatórios e na prática clínica?
See, okay. So when you term the waveform monophasic, everybody knows that and is the one that has only forward flow and absence of flow in the diastole completely, right? Then this is pathologic in all conditions. Okay, nobody argues. A triphasic waveform, most of the time is normal, but sometimes you have triphasic waveform that's abnormal. When you have a concentric stenosis and the blood cells go in the same direction, you have triphasic waveform. You have higher velocities, but you have triphasicity. So triphasic waveform is not always normal. And then on biphasic, as you said, depending on the arterial tree that you are, if you are in a low resistance tree, that waveform is normal. If you are in a high resistance tree, that's abnormal. And I will make all this no other categorization because these are sufficient to cover 95% of the pathology in the routine clinical practice. And it's less confusing.
E quanto à baixa e a alta resistência?
Yeah, this with the resistance because goes together, Arthur, is very important because many people are confused. Basically, the resistance in the artery is seen very well by the end diastolic velocity. The end diastolic velocity represents, right, the time during which blood moves with its own momentum because the heart is resting. Therefore, during this phase, right, you have the sum of all the resistances past the measurement. And the higher the diastolic velocity, the lower the resistance. And that's why this is a very important measurement we use for different conditions, normal and abnormal. For example, if you look at the superior mesenteric artery, during fasting, because most of the mesenteric capillaries are closed, there's high resistance. When you eat, with 15 minutes, you get the stimulus, all the capillaries open, and the flow goes very high, and it reaches the highest point at 40 minutes, and gradually declines, and at 90 minutes to 2 hours, goes back to normal. So you see, you can study physiology this way. Right? Or when you have people with still phenomena, for example, the waveform could be barely normal or abnormal to begin with, but becomes clearly abnormal when you exercise the patient, right? And I think that we should leave it at that. That's enough for not get more complicated.
Essa é a importância do ultrassonografista saber, né, o que ele está avaliando e toda a característica clínica do paciente, senão ele pode acabar se confundindo mesmo.
Yeah, Arthur, to give you an example, which is very that clear. For example, the internal carotid distally or the middle cerebral artery is high in diastolic velocity. If the end diastolic velocity is negative or zero, this is an excellent diagnosis of brain death, right? Because the blood goes to the brain but cannot be used, for example, or in the kidneys. If your resistive index is more than 0.8, you have severe parenchymal disease. And in such patients, if you put a stent, you don't make any improvement on number of medications, and you can harm 1 every 10 patients. So that's how you use the resistance in a meaningful manner to make decisions for your patients.
Ou seja, né, não dá para generalizar e usar de uma única forma, né? Tem que ser pontual mesmo para cada paciente. Dr. Nicos, existe uma confusão, especialmente nos ultrassonografistas mais novos, entre a diferença de estenose de diâmetro e estenose de área. O senhor comentou isso agora há pouco. O senhor pode nos explicar essa diferença e qual dos dois é mais significativo?
Yeah, because our arteries are a full circle, the vessels are cylindrical, the diameter and the area stenosis are equivalent, but they're different numbers. A 50% diameter stenosis is equivalent to 75% area stenosis. Now, if for whatever the reason you have an irregular plaque inside the vessel, so the inside area you have to have too many diameters to figure it out, you can use the continuous trace of the ultrasound and measure the inner area versus the circle, the outer area. And the machine will give you precisely the area reduction. However, many people make a mistake. They put 70% stenosis, but don't say if it's area or diameter. You have to declare if it's area or diameter. Because if it's 70% diameter, it's 90% area. If it's 70% area, it's less than 50% diameter. So you have to make sure what you measure and declare on your note, write down if it is area or diameter, and more importantly, you have to have objective evidence. You have to save the pictures to show exactly what you did. Because I've seen often, even in the United States, people have measured the area and they call it diameter. And you understand this can be devastating because you can over-treat in this occasion or under-treat if it is the opposite.
Aqui no Brasil, habitualmente vem medido o diâmetro, né? Eu não vejo o pessoal colocar a medição diária nos laudos. Habitualmente a gente usa o diâmetro.
The diameter is very good and it's the most constant measure in people. But in case where you have a plaque that's very regular, what will happen? Because if you measure one view, look at my finger. If I go like anterior-posterior in the flattened vessel or area, right? Then this diameter is smaller than the horizontal one. So if you use the diameter, you have to use what we call triaxial, like with the angiogram. 3 different views at least to make it more accurate. And then 3 diameters and divide by 3. Triaxial. Because for reasons that probably is inherent to human nature and people perform diagnosis, we like to find disease. And that's why most people are overdiagnosed, because people get happy to find disease. And that's why it's easier to measure the anteroposterior diameter instead of say, like with the IVUS now, to see 360. Obviously, 360 is better than 1 view. 2 views is better than 1. And 3 are better than 2. But in terms of diameters, if you measure 3 views, you're, very close to the real value.
Dr. Nicos, o senhor comentou previamente uma das formas de calcular a estenose da parte arterial. O senhor poderia comentar com a gente qual é o conceito de uma estenose hemodinamicamente significativa?
Well, not to have any confusion, hemodynamically significant stenosis is the one through which the blood reduces its flow or pressure. Unless the pressure or the flow is being reduced, there is no hemodynamically significant stenosis. Now, this we know because in animals, we have put catheters for direct pressure measurement before and after the stenosis. And this value in animals, right, is about close to 60% diameter reduction in most blood vessels. But in medicine, we use the 50% because it's easier to remember. And in fact, for most blood vessels, the difference is very small. So 50 to 60 so 50 is very close to the 60, right? And now, with the ultrasound, you can see for these values, the ratio, which is more than 2. You see, post-stenotic turbulence. Any vessel that has a stenosis of more than 50% is to produce turbulence for at least 2 centimeters. And if the stenosis is more than 75% in diameter, the post-stenotic turbulence should persist for at least 4 centimeters. So the combination of seeing the post-stenotic turbulence and the change in the post-stenotic to pre-stenotic velocity at least by 2 would indicate that the patient is very close or actually having a hemodynamically significant stenosis. But one thing people fail to understand, and it's very easy to see with the people with claudication, sometimes stenosis become significant only after exercise. So somebody have a stenosis that hemodynamically not significant at rest, but after exercise becomes important. Why is that? Because at rest, the supply meets the demand. And during exercise, the supply does not meet the demand. So the famous law that came from Mr. Dr. Locke from England, right? The law of supply and demand, which is universal for finances, commerce, and also our arteries and our human body.
Professor, ainda no campo arterial, em 1998 o senhor publicou no Journal of Vascular Surgery um artigo pioneiro em relação ao tratamento dos pseudaneurismas com injeção ecoguiada de trombina. Hoje, esse tratamento é preconizado e utilizado aí pela maior parte dos cirurgiões mundo afora. O senhor se lembra e podia comentar um pouquinho aqui com a gente como é que foi, de onde que surgiu essa ideia lá atrás, na década de 90?
So, as I said earlier, it's our life is a combination of random events. And to me, it was just, by chance that I happened to go to Chicago. In Chicago, one of my colleagues, Dr. Stephen Kahn, when he was a fellow the year before, he was making fibrin glue in the basic science laboratory. When I went to the States, I was one of the few people in the world that was familiar with ultrasound guided procedures. That is 1995, right? So he knew about the thrombin, I knew about the ultrasound techniques. Both of us together, we thought like to inject the false aneurysm. However, to do this, we have to create an animal model because how can you inject humans with thrombin? The box out says, do not inject, right? and then what we did, while we were planning to do the animal experiment with Steve, one patient that cannot undergo operation had a false aneurysm. It was actually the subclavian artery, and it's difficult to put compression, you can do nothing, you have to do open surgery. And the patient could not have open surgery. So the hospital gave us permission for compassionate use to use thrombin, right? If you use thrombin, it worked right away. It was a miracle, it's amazing. Then the institutional review board of our hospital, it gave us permission to use it actually in humans. We had the idea just to use animals. And when we started the humans, it worked fantastic in all people right away. So, and then we did the publication in 1998, but we didn't work in the previous 2 years. And then in 2003, it developed a billing code. It's a procedure you can do and actually charge money to the hospital or the people for this. And it's been used all around the world now with a success rate of 95 to 99%. And this is regardless if the people are coagulated or have antiplatelets. Because thrombin, remember, no thrombin, no thrombus. Thrombin is the final path of the coagulation cascade and bypasses both the extrinsic and intrinsic pathways. You need only circulating fibrinogen to make fibrin, which is basically the thrombus. That's why thrombin works all the time, no matter if you're fully anticoagulated. And to me, it's fascinating because it's also luck, good work and luck. Because in our lifetime, it's not often that we discover something simple and brilliant that can be used every day at a very low cost, being very cheap, have no side effects if you use it properly, and avoid major surgery and even death.
Caramba, em 95, hein, Luiz? Onde é que você tava em 95? O Dr. Nicos já tava publicando cola.
Eu tava sendo alfabetizado, né, com aquela dificuldade.
Tava no ABC, né?
Tentando ser alfabetizado. I didn't tell you, Fabio, one of my trips in Brazil, right? I have a friend of mine who's a cardiologist in Rio de Janeiro. And he had a friend who was also a cardiologist. His name is Antonio Nogueira. And he was fascinated by my technique. So there is no thrombin in Brazil at the time. So I brought thrombin from the United States, and I saw him how to do it, and he performed with me the first thrombin injection actually in Brazil. And this is how the technique started almost 18 years ago in Brazil.
Uau, que história, hein?
Rio de Janeiro.
Professor, e tem alguma condição técnica que o senhor fazia em 98, 95, que o senhor mudou hoje em dia?
So what we do right now, we have more experience. We try to inject away from the neck, because usually the neck has to and fro flow. Flow goes outside the artery, comes back inside the artery. So if you inject close to the neck, you can give thrombus inside the artery, you get in trouble. You need to go to the operating room or anticoagulate the patient. Number one. Number two, if the patient has no neck, we try not to inject, because if there's no neck, it's easy for the thrombin to go inside the artery. And number three, if the defect, right, the opening of the artery is more than 5 millimeters, it's too big of a defect, so you try not to inject there. Furthermore, if the patient has multiple pseudoaneurysms that connect with each other, we inject the one which closer to the neck, because with a single injection, you take care of everything. For example, the patient has multiple aneurysms with a total size of 13 centimeters. By injecting the first aneurysm, which is 2.5, everything occluded. Because if you include the entrance, then no blood is going and everything gets thrombosed, right? And then also we try to use now lower dose, inject very slowly. We see if the aneurysm occludes in front of our eyes, we move the transducer up and down. And then, without taking the needle out, we inject as appropriate, so you don't have to re-puncture the patient again. So the same puncture, right? And another thing we do, just imagine, I can say it, but you can explain to the people. When we do the imaging, we don't go in cross-sectional view like we do the arteries, or the veins to enter. We look at the long view, right, which is a cross-section of the pseudoaneurysm, and we go from the side. So the needle is always seen longitudinally. You never lose the path of the needle. It's very easy. It's much easier way to find it, if you don't have much experience.
Bom, nada como pegar umas dicas do criador da técnica, né? Acho que
sem dúvida. E a gente tá vendo, né? A galera que tá escutando isso tá tipo, putz, queria ver também. Bom, o que ele tava mostrando aqui pra nós é que é melhor você funcionar em plano do que fora de plano, né? Facilita a tua técnica.
Acompanhando a agulha aí pra não... E, doutor Nicos, vamos mudar um pouquinho de assunto. Achei nítida essa relação que o senhor tem com o Brasil, né? A gente pode ver que o senhor fica bem animado quando a gente fala daqui, da sua relação que o senhor tem com o pessoal daqui. como que isso começou e eu queria saber também com relação à nossa medicina, qual que o senhor acredita que seja, digamos, o nosso maior problema e até a nossa maior vantagem, se é que poderíamos chamar assim.
Very nice, Luis. This is for me, it's very close to my heart. Porque I was invited in Brazil by some friends, American, Brazilian friends, about 21 years ago. So I went to the first meeting in Rio de Janeiro. And then immediately, either because I'm Greek, Mediterranean, the culture is similar. So, and me, I'm very open person, and I'm very simple. I don't like big things. I like to be close to people, right? So I made many friends in the first trip, and then I opened the door for many Brazilians to come and visit me, when I was in Chicago or in New Jersey and in New York. I probably have accepted so far maybe more than 200 Brazilian doctors have come to see me. And I try to help them as much as I can while they're here, right? I mean, I'll tell you the stories is sometimes I'm so honest, some of them, they even cry because they see how much they miss learning, right? Or because when you have hard working in Brazil, you don't have the opportunity to go to a place to really learn very often. And brings you memories, makes you thirsty for knowledge. And me, it's very close to my heart because I want to teach. And sometimes when I come to Brazil, I feel sad because I cannot accept como é possível a pessoa como eu, que está mais ou menos metade brasileiro, ama Brasil mais que brasileiros. Não pode entender isso. But I really love Brazil for whatever reason. So much also by a random event. In 2008, I met my wife in Rio de Janeiro. Her name is Yanni, and she's a cardiologist. She used to work in Sao Paulo. I went to a cardiovascular meeting. Again, by accident, Dr. Arno von Risto, who's a good friend of mine, he invited me to cook at his home for his family. And he was delayed, and me had checked out already from my hotel. So I went back to have a breakfast waiting for Dr. Arno. And then I met my wife. We did not meet at the meeting, just met at the breakfast. When I have already checked out, if Arno was not delayed, I would never meet my wife. Her name is Ziani, her daughter is called Diana. My daughter, her first language is actually Portuguese. She speaks perfect Portuguese. And we fly every year to Brazil at least once to see our family. And right now in 2021, it's difficult to separate Greece and Brazil, basically, right? I would say like in the States, that close. It's a very, very emotional, unexpected, spontaneous, phenomenal thing, in the trip of life.
Se eu não me engano, professor, ela é formada pelo Instituto Dante Pazzanesi de Cardiologia.
That's correct.
Foi aonde o Fábio fez a formação completa de vascular e aonde eu fiz parte da minha formação também. A gente passou por lá.
Fantástico.
Agora eu tenho uma pergunta para o senhor. A gente entrevistou o Dr. Arno aqui alguns meses atrás. Eu queria saber se ele é tão bom cozinheiro quanto ele é bom cirurgião vascular.
Não sei porque, eu sei a esposa dele, seguro, mas Arno sabe como comer, seguro. He's a very good friend, it's amazing. I think it was like in a meeting of the Society of Vascular Surgery of Brazil, right? That I was his wife and we were talking about food. His wife had a restaurant. And then we said, well, when I come to Rio, it's, by the way, no offense to any other city, I believe Rio is one of the most beautiful cities in the world. I think together with Cape Town in South Africa, that probably some of the best natural beauty, right? Even if you remove the buildings, the people, everything. Not to say in an intimidating fashion with the rest of the beautiful Brazil. It's just like a natural phenomenon, really beautiful place. And there, I had the opportunity to go to his home, and we went actually to the supermarket with Arno, because I tell him, Arno, I have to select everything with my own eyes and hands. And by the way, we not discuss, I cooked several times in Brazilian events. I cooked for a Brazilian meeting in Goiânia with my friend Panilda and Sandra and all other Brazilian friends. And then I did also make for the faculty of the Society of Vascular Surgery of Brazil in Goiânia in 2007 with my friend Rui Nunes. I went to his home and it was fantastic. It's really nice to get a little bit, to get the culture, to understand the people, mix Greek Mediterranean and Brazilian cuisine, and it's more fun. I mean, life is more than medicine, obviously.
Olha, não vou negar que me deu fome, que eu também estaria disposto a aceitar. Bom, doutor, continuando a falar do Brasil, então, a gente sabe que aqui no Brasil a flebologia vem crescendo exponencialmente e que seu braço da estética ainda mais. Sem dúvida, os brasileiros dominam a arte de tratar as varizes, as telangiectasias, enfim. Esse mercado existe nos Estados Unidos? Como que isso funciona por aí?
I must say, Fabio, that this market is exploding in the United States right now because multiple specialties, treat people with varicose veins, particularly with the, evolution of endovenous techniques. Because in the past, you had to be only surgeon to do that. But now, because of the injections and the ablation techniques, other specialties, including cardiologists, interventional radiologists, dermatologists, treat such patients. But ironically, like anything else in medicine, people with venous disease can be overtreated, receiving treatment when it's not necessary, and many people who need treatment, like people with ulcers, don't get any treatment because they are in a wound care center that they have a vicious cycle. They put the bandage, they heal the ulcer, right? Then the patient gets new ulcer, they put the bandage, this is how they make money. But for the most part, I think the market is involved in the correct direction because more people have the proper treatment, but the physicians have, for the most part, good training.
Professor, e a próxima pergunta é sobre carreira e mercado de trabalho. A gente sabe que na medicina, e especialmente nos métodos diagnósticos, a realidade da inteligência artificial vem causando grande impacto, em especial na tomografia e na ressonância. Como o senhor enxerga a ultrassonografia vascular nos próximos 10 anos e também nos próximos 20 anos?
I think, Arthur, what will happen is happening already. 3D and 4D ultrasound will become a routine clinical practice, not research anymore. And this has various advantages because it will, let's say for example, now you have a patient who has an atherosclerotic plaque in the carotid or in the femoral artery, and you give hypolipidemic drugs. You can now tell instantly without any reconstruction if the plaque is increasing in volume or decreasing, which to me is a better marker than the stenosis itself, right? So that's one example. Then I think what will happen is even the reconstruction will become automatic, and after you finish the scanning, right, you have like the 3D appearance of an aneurysm of the aorta or an aneurysm of the popliteal artery. And seeing this map directly, you can make a decision like in the CAT scan, how to treat it. What is your proximal addison, the distal addison, etc. The technology is here, it just needs to be applied and do the clinical studies to confirm this. But I think in the 20-year margin that you put, when I was in the university, we learned in the advanced immunology about the epitopes, basically the proteins that serve as a markers on our cells in the human body. Now we have ways of identifying epitopes with markers, and I believe ultrasound could help a lot in guiding the treatment by combining techniques of molecular biology and imaging. And I think ultrasound, because it's so portable, right, it could help pioneer what we call the targeted treatment for the patient. For example, if you find special cells that have a special marker that the ultrasound can guide you there, or it can set the markers there, right? You can go to these cells only and nothing else, period. And you have what we call the future targeted cellular treatment. Will maybe be extremely important for atherosclerosis, for cancer, and other conditions.
Muito legal. E, doutor, agora mudando um pouquinho de assunto, todos sabemos que o senhor coordena o Venus Symposium em Nova York, que o evento é um grande sucesso, vem ganhando anualmente cada vez mais espaço. Tivemos essa questão de 2020, que foi um ano atípico, né, em decorrência da pandemia, mas e esse ano vai ter o congresso? O que nós podemos esperar desse congresso em 2021?
Yes, we have done the program already because here, I like to work ahead of the game. So our meeting is going to be in April 15 to 17. It's going to be virtual because we have to be good citizens, right? Now the world is in a major distress, right? Because of the pandemic. And priority right now is safety and taking measures to reduce the transmission of the disease and if possible to eliminate it so you can go back to normal life. In fact, we have also what we call the arterial symposium, which is going to be in July this year. Even this meeting in July is going to be virtual. Hopefully, my good friends, we can start having meetings in 2022 and hopefully I'll be able to travel in Brazil because usually I travel 2 or 3 times a year in Brazil. and I really enjoy going there. But this year I haven't been, obviously because of the COVID situation.
Professor, o senhor já ajudou e vem ajudando muitos brasileiros ao longo dos anos. Qual mensagem o senhor gostaria de passar para um jovem cirurgião vascular que está iniciando aí a sua vida profissional?
Very nice. I think all of us have to study hard, but more importantly, learn. See, in physics, there is a term, it's called absorption. We use it on the ultrasound. Absorption is when you convert one form of energy to another. Like in the ultrasound, you convert mechanical energy to heat because the tissues absorb the energy, they convert the mechanical energy to heat. So I made a term for our medical students, I call like the absorption index for learning, right? Is if you sit down on a chair and study, it's not enough. You have to convert studying into learning. And the best way to learn, Fabio, is to eliminate the gaps of knowledge from your previous life, right? Not everything, but important mechanisms, important parts that don't allow you to understand medicine better, right? First, we have to cover our gaps, study hard. Then, we have to embrace evolution in technology and not be afraid with the new technology and learn all the new things and adapt them, become what we call early adapters, so you have better progress in our life. But very important, we have to learn to be patient, respectful, and keep an open mind. Because you have to have a keep in mind to be have imagination, to be a dreamer. Do you know, for example, that Einstein, right, long time ago, he said that imagination is superior to logic. Because if you use your logic all the time, Fabio, you can become only more stupid. But if you use your imagination, you open new horizons, you go against the odds, and you make new discoveries, right? And that's a beautiful. Imagine, Julius Verne, when he make all these beautiful stories, and most of his stories become a reality because he helped people to dream, right? We need dreamers in this world, right? And also if you know the Star Trek, right, by Gene Roddenberry, it is said there, right, because people see things traveling into space, impossible things. It was said there that today's fantasy is tomorrow's reality. And I think every Brazilian doctor has to dream, become a dreamer, and love his work. Not to do the work just because earning some of money, that's very important too, but because you love taking care of the patients, you love progress, you love teaching others, you love taking care of the public, right?
Dr. Nicos tem uma pergunta que a gente sempre faz para os nossos convidados. Existe alguma coisa ou algum conceito que a comunidade científica acredite, mas que o senhor discorda?
Look, there are many areas that, by tradition, the teaching is wrong. Let me give you some example. You learn when you go to medical school about the Laplace law and the aneurysm ruptures because of the Laplace law, right? So if you have like the bigger diameter, you have, makes the wall of the aorta to weak until it breaks, like a balloon, right? That's not true. In 2011, with a big grant we got with the University of Liège, which demonstrated that the rupture of the aneurysm occurs because of local stress heterogeneity. There is an area of high stress and low stress together, and this heterogeneity stress stimulates the MMP2 and 9, right, that digest the collagen. And in some people, not in all the people, this leads to rupture. In most people, the human body heals this reaction, right? This high metabolic activity, and you may get it at another area or the same area later again. But you see, the Laplace law, the medical school was so simple and makes sense to your brain, it's not true. And even in 2021, this has not been in the books. It has been discovered from us 10 years ago. Another thing, if you go to medical school and learn about the Virchow's triad, right? You know, Virchow never discovered the triad. It would be impossible because, you know, the first thrombophilic factor that was discovered is antithrombin. It was discovered in 1963. So it would be impossible for Virchow to discover. But more importantly, Virchow never said that he described it. See, Virchow was a very pompous guy, very selfish guy. If he finds something, he would say to all the world to know that I did it. He never said that he did. In fact, his contemporary professors at his same own time criticized him that did not give value to the endothelial injury. And in fact, there is a beautiful paper in British Journal of Hematology, right, in 2009, that describes very well the history of thrombosis. And although Virchow was brilliant, did not discover the Virchow's triad. What Virchow described basically is very fascinating. He described the mechanism of pulmonary embolism. He took dogs and he put small metallic spheres in the jugular vein of the dogs. And he figured out the metallic spheres end up in the lung. Then to make sure, he made blood clots, and the blood clots also went to the lung. So he discovered first in the world that pulmonary embolism, embolia, he gave us the term, it comes from a vein thrombosis, basically. But you know, as you know, until now, tradition is stronger than science, and it's very difficult to get rid of tradition. For example, we call the iliac vein compression May Turner. It's totally erroneous and incorrect. This was discovered in 1906 by Dr. McMurray, a Canadian doctor, and it was published in a good journal, the British Medical Journal. And then in 1957, 51 years later, May and Turner said exactly the same thing. And more importantly, there is no May-Turner syndrome. The word syndrome, right, it was done by Dr. Cocker in 1967 in the British Journal of Surgery. So you see, so many things are wrong, you know, but you cannot stop people all the time correcting them. But since you ask, I tell you, there are many, many things that we do wrong. But we have to be patient and learn what is the correct thing to do.
Doutor, a gente deixou uma pergunta por último, bem curiosa, porque o senhor falou que já morou em vários lugares, como o senhor falou na Inglaterra, na Grécia, que o senhor nasceu, nos Estados Unidos, no Brasil. Uma pergunta que deixou a gente muito curioso foi, numa Copa do Mundo, quem que o senhor torce? Grécia, Brasil, Estados Unidos, Inglaterra? Qual que é a sua preferência aí?
Luis, when I saw the question for the first time, I was puzzled. But when I look logically, there is no puzzle, right? I probably am equal between Greece and Brazil. But you see, Greece is no very good team. So if we don't go, or we go, we get out quickly. So the only thing left for me is Brazil.
Teve aquela Eurocopa que vocês ganharam em cima de Portugal.
Yeah, that was a fantastic thing, once in a lifetime. But Brazil has a great, story and equipment, equipo for many, many years. I grew up with my cousin Eugene. He's a civil engineer, and the brothers of my mom, they like football a lot, like most kids alike, And they used to know all the Brazilian players, their names, their profession, their scores, and I followed that because I was hanging around with them. And I saw also videos from the Pelé, Garincha, and then later, the Zarzinho, Rivellino.
O senhor já está falando mais nome do que o Fábio conhece.
No, it's beautiful. I mean, football.
Fábio se perdeu agora. É melhor voltar para vascular, né? Ou melhor para indo.
I like the Brazilian culture, and sometimes, particularly with the music, I make fun of my friends that they do not know a lot of the facts about the Brazilian music. And but it's funny, every country has its own culture, tradition, story. But Brazil, because it's a big country and so much influence from many different things, is a wonderful, culture and And for me, it's been really, I would say, a privilege to share the Brazilian culture and be part of it.
Legal, muito legal. Ô Fábio, antes de eu encerrar, eu queria saber onde que a gente vai jantar aqui em Manhattan. Você separou algum lugar? Eu tô cansado do voo fretado.
Tem um bistrozinho ali na esquina da Quinta com a 42 ali, tô pensando em levar vocês ali.
Professor Nicos, a gente está chegando no fim do podcast. Se o senhor tiver alguma mensagem final para deixar para os ouvintes brasileiros e também o seu contato e também o contato do simpósio, tanto do venoso quanto do arterial.
Absolutely. First of all, I want to give the message I want to give to my Brazilian friends. I say them all the time. You have to remain simple. What defines you is not your education and your titles. It's mostly your character, being a nice person. So that's why myself, when I go to Brazil and also in my hospital, I don't like people call me professor or doctor, because I am Nicos, you are Artur, Luis, and Fabio. We're all equal. There is a philosopher who raised in Greece, not Socrates, called Isocrates. And this guy, he said, there should not be slave and free men. Everybody's equal. If you take the same air, right, the air with the same nose, you use the same hands to put food in your mouth, by definition, everybody's equal. And that's why I believe, right, people should be modest, not to be selfish, and be very happy to work together. And to use a Greek word, it would be synagonistic and not antagonistic. It's very beautiful to coexist and work together. I understand we're humans, we have, ambitions, we have selfishness, but the sooner you tame your ego, the easiest the way to be more happy and be more successful. Right? And to me, taming our ego is the first, step to enjoy success and happiness. And I don't try to be philosophical, but I want to be realistic, because nowadays we measure success by the titles we carry and the amount of money we make. And to me, this is the wrong measure of success. Not success as well too, right? But success and achievement could be you can make a beautiful food that people can enjoy. You get a nice poem that people can like, right? A beautiful music, a beautiful painting. Success is measured in very different ways. And I think, as I said earlier, learning of how to coexist together in a friendly way, and particularly the medical world, because I believe we are very privileged to be doctors, because it's a noble profession, right? And we have the opportunity, right, to exercise this privilege daily. Unfortunately, we use also this privilege for very selfish reasons. And that's why first we have to become like better humans, all of us, me and all of you together, right? And that's the way, right, to see a better world for the future. Regardless of any discoveries, any treatments, first you have to be a very good human being. And that's the message I want to give to all my Brazilian friends, with actually a lot of love, right? Because love is unconditional, it doesn't expect anything back. That's the biggest advantage of love, You remember when Pele played his final game, right? Cosmos versus Santos. He finished with 3 words, like love, love, love. And him and many others, because it's the most pure thing we have. And I said again, I don't want to be like cynical or philosophical. I want to be realistic and live with a simple message, right? And that's why when I start to Brazil, I feel this emotion, I feel the love.
E esse momento que acho que a mensagem que o senhor está passando, ainda mais esse momento que a gente está vivendo com a pandemia, acho que é muito importante, de uma forma geral, para todos os nossos ouvintes, não só em termos profissionais, né, mas com uma mensagem de vida aí também.
Obrigado mais uma vez, professor Nicos, por abrir espaço na sua agenda para conversar com a nossa equipe. E chega ao fim mais um episódio do Frêmito, o podcast vascular do Fogart da Madrugada. Compartilha com a gente aonde você está escutando esse episódio do Frêmito. Faz um print screen da tela e compartilha no nosso perfil do Instagram. Compartilhe também as suas imagens utilizando o catéter Fogart. Não deixe de conferir e participar das nossas postagens. A gente se encontra no próximo episódio. Até mais!
Frêmito, o podcast vascular do perfil O Fogart da Madrugada.